Technology adoption among older adults is growing, and there's no signs of slowing down. Today, we will hear from 3 leaders and innovators showcasing some of the most exciting new home technologies and care delivery models poised to play a greater role in seniors' lives in this year and beyond. Please welcome the moderator for this session, Sherry Rose, Chief Executive Officer of the Thrive Center.
Thanks, Steve. And we're excited to be here with the panelists. You're going to hear some amazing innovators today. So thanks to Modern Healthcare for this opportunity. As the Thrive Center, we are established really as a nonprofit innovation center focused on wellness and aging. And in our center, we have a lot of products on display. I'm always asked, why did you build such a center? And it's like, where do you go to see innovations in aging? And so the Thrive Center is that place where when we see innovative solutions that can transform quality of life, we bring them into the center and we expose them to an industry. Our mission is to transform quality of care and quality of life for aging adults, who most of us will be aging at home. We always look at the home as the healthcare hub. So I'm really excited today to introduce our speakers who will be presenting some innovative technologies that you likely have not heard of, and they will walk through some of their innovative solutions. First, we're going to have Deepak Gadapati. He's the founder and CTO of VirtueSense. He managed R&D for the U.S. Army, resides in Peoria, Illinois. Something he is very humble and may not say about himself is he was also the architect of the TSA body scan. And so he took his knowledge from all of the research and development that he did and founded VirtueSense. Next, you're going to hear from Vic Kashyap. He is the founder and CEO of Toy Labs. He has a Bachelor of Arts from Harvard, and he also is a serial entrepreneur. So you will see a lot of startups that he has worked with out of Silicon Valley. And then next, you will hear from Mike Dooley, who is the co-founder and CEO of Labrador Systems, BA from Tufts in psychology, which is, that's also what my bachelor's is in. So we're in good company, Mike. And then also an MBA from Stanford University. Their company resides in the Los Angeles area. So as I turn it over to these innovators, you're going to hear about a product with VirtueSense that's in the market. You're going to hear one from Toy Labs that's coming out of a pilot. And you're going to hear from Mike on Labrador Systems on in pilot stage and some of the technologies that they're looking at. So we're going to turn it over now to Deepak and let him talk about VirtueSense.
Thank you, Sherry. So at VirtueSense, we are advancing the transformation of proactive healthcare for all. And we accomplish this through an ecosystem of AI, data, and innovative sensors. So as Sherry said, my background is in machine vision AI. So after developing the first system that is used in for looking for explosives on people used in most airports, I started working with DoD. And during this process, when I was working with DoD, my grandmother, who's 60 years old, she fell, broke her hip, and died as a result of a fall. So that's what prompted me to start VirtueSense. So today we are a company that is very heavily focused on preventing falls that happen in the community, in the hospitals, and in nursing homes. So VST Balance is a system that identifies, that is used by basically primary care, neurology, and orthopedics to identify who's at risk for falls in under 2 minutes, objectively using evidence-based medicine. And the system figures out, what kind of deficits a person has, a senior has, and gives a risk in terms of they're at a 60% risk for fall in the next 12 months or 10% based on their various evidence-based tests. And once we identify the risk, then we have a program, through a clinical program through which the clinicians use the technology to provide at-home exercises using mobile apps or get referred to various specialty care. As a result, we've been able to reduce falls with injuries by over 73% in a study we did by working with CMS. And additionally, we are improving mobility of patients by over 85%. And all this, still we have some reimbursement codes for physicians to use in Medicare settings. So the next product we have is VST1, which is a in-room technology that is focused on preventing falls initially before COVID. So it's a LiDAR sensor that goes inside the room. So typically you use pressure pads or you use sitters or e-sitters to make sure there are less than 1 million falls in the hospitals. And what this piece of technology does is it's extremely predictive, and it uses LiDAR and reconstructs the whole room 30 times a second and figures out where is the bed, where is the patient, where is the chair, and what are the patients doing to get out of the bed. And using 2 million such hours of data, we trained AI that identifies 30 to 65 seconds ahead of time before the patients get out of the bed. As a result, we've been able to reduce falls with injuries by over 95% and false alarms by over 96% across various health systems. On top of this, we also enable real-time virtual visits because the sensor is equipped with a 4K camera and an array of microphones. So additionally, we have a patch that goes on the chest that automatically measures all the vitals, all the way from blood pressure to pulse ox, heart rate, ECG, and respiration rate and core body temperature once every 15 minutes, and alerts the clinicians when it observes anomalies. As a result of doing this, we've been able to help nurses take care of more patients in a more effective place and preventing falls and other conditions like heart attacks and respiratory failures. The final product we have is VST Care. This is a product that we are launching out in next month. So this is a wearable that you put on your, like a watch or on your arm, that automatically measures all the vitals once every 15 minutes. The arm wearable has a GSM 4G connection, so it automatically sends this vital data once every 15 minutes to our HIPAA-compliant cloud, and there's an AI that is continuously monitoring, and if we see any anomalies, at that point we automatically alert the virtual care centers in various hospitals, or we even help set up a virtual care center through which you can have a televisit with the patient and monitor them and escalate if need be, or bring on physicians to take care of these patients. That's our product portfolio today. And I want you to introduce to Vic Kashyap from Toy Labs at this point.
Thank you, Deepak. Hi, everyone. My name is Vic Kashyap. I'm the founder and CEO of Toy Labs. Toy Labs is really at the frontier of a new type of tracking of data, stool and urine from the home. All right, so there are millions of hospitalizations that occur in senior populations every year that are due to gastrointestinal and urinary issues. The fact of the matter is many of these hospitalizations are actually preventable. Today, however, there's no way to observe what is going on inside the toilet of individuals today to give insights into these specific conditions. Trulu is a connected toilet seat. It's the world's first connected toilet seat. It can be affixed onto any toilet in a matter of minutes. And while it may look like any other toilet seat, it's actually got a lot of technology embedded in it. You can think of it as having a set of experts in urology and gastroenterology who are essentially peering into the bowl of an individual on a daily, continuous basis with no effort. So what we provide today to nursing homes is a daily report that captures information that is typically either needs to be self-reported or collected by caregivers inside these environments. These include things like, is the individual bleeding? Do they have loose stool? Is their urine patterns or other types of bowel or urinary patterns off? We're able to, using very advanced techniques, able to collect and understand when there are these abnormal patterns and be able to provide visibility into that. Really, the goal of this is to enable early interventions. Trulu has been deployed and well accepted as part of a set of clinical studies that we have performed as a company. I think one thing to note here is that 90% of participants who used the TrueLoo during the clinical study said it required zero effort to use. And in this particular population, older adults, user acceptance is critical, and using something like a toilet seat that's integrated into their day-to-day life makes it very easy. We really view the analysis of stool and urine from the home as the next major vital sign. And as the medical community and other individuals see the type of data that we're able to provide, they agree that this type of information has always been used in medicine. But today, for the first time with the TrueLoo, we're able to provide this for everyone. With that, I'm going to introduce you to Mike Doolittle. Mike, please take it away.
So thanks, Vic, and thanks for Sherry for having us on. Today we're going to talk about a new robot that's designed to help people live more independently in the home. And so we're really looking at populations of folks that are aging in place or have other sorts of impairments or early onset. And basically we're in pilot studies. So the trick here is we're not going to publicly show you the robot we have, but if you are interested in following up, we can show a lot more in terms of looking for partners for pilots, getting into the features, and even some of the initial user feedback. And we're going to give you a high-level preview, a little bit more detail than we've shared before. What the product is, you really think about it, it's designed to physically assist individuals in moving things. We basically help people carry the laundry basket or help them set the table or bring their medication within reach. So we're basically focusing on populations where folks that either have pain or other impaired mobility issues have some restricted ability. There's something blocking them from getting up and getting that glass of water or doing the daily activities that they used to do. And our first focus is really to deliver to folks a new tool for daily independence. Our mission here is that this helps my mom or helps whoever that person is do more on their own, rely less on caregivers or on family members for certain types of activities where they can sort of maintain their independence, as well as where it's more heavy lifting or more, let's say, getting someone who might be in a bed or in a wheelchair quite a bit of the time, helping extend the impact of caregivers as they go on. And what happens when we do this is we get new opportunities, I think, both for improving health outcomes in terms of just the activities that people engage in, but also new ways of looking at data. So a lot of these new tools that some of the other speakers are talking about, if you put those on a mobile robot, you get the ability to sort of put those anywhere you want in an environment. So we really look at what we're trying to do is not really competing with all the digital technologies that are coming up, but actually being a platform that can move those around. So again, what we'll get into is just a quick overview. So you can think of the robot as, think of it as about the size of a kitchen cart or something on that ability. It's large enough to carry things like a whole tray of meals or a laundry basket, but also can bring things like retrieve core items like bringing fluids or bringing medication on a schedule. And the way we describe it to folks, especially when we're talking to seniors, is think of the robot as having bus stops. And the bus stops are the places the robot can go. And you can command it in a lot of different ways. You can use Alexa to sort of say, Alexa, ask the robot to go to the living room, or hit a button on your iPhone, or even we can make just a simple button that you press. And the whole mission is to sort of move the robot as a sort of work surface from one place to the other. And for instance, if you're going to set the table and you may want to send it off to the kitchen to say, basically take your utensils, plates, and your food, the drinks, everything, and then send that off to the dining table. The robot autonomously drives there. If the dog or cat is in the way, it'll scoot around and parks itself so that everything's within reach. And we repeat that type of activity of basically just moving things where people need them when they are. And from there, we can extend and do more things, like we can start getting into automatic reminders. So if someone is, they've forgotten to take their medication, we can physically bring that to their location and act as a physical reminder for what they're doing. So, and from there, what we look at is those types of cases could be like, help me set the dining table, as I said, but also help me stay hydrated, like keep water, keep fluids within reach. Common one that's happened in the pilots for people with COVID is in isolation is like bring the Instacart delivery from the front door. Let me sort of put that all together and send that off to the kitchen. but it can be all these sort of activities. And again, we're really focusing on both the early onset, folks that are just starting to have those issues. It could be someone with arthritis where it's very difficult for them to carry that full laundry basket, or that sort of they're having to shuffle a lot to go back from place to place when they're setting the table, to folks that, like my mother, who are now either in a wheelchair or in our bed, and maybe waking up like 2 hours or 3 hours before the home care folks are coming. And what can we, she's thirsty or she needs a blanket. And so could the care providers actually preset some of those options and then have those available when they're not there? And our mission here is not to replace the caregivers at all. Those high human touch activities of daily living, when you get to those levels of need, I don't know how long it's going to take, but it's going to be a very long time to where robotics are doing sort of full human sort of functionality there. But what we can do is start off loading some of these more basic tasks, let people live more independently, relieve the caregivers of some of these activities, especially for the hours that they're not there. And what I just wanted to leave you with is the summary. We're really excited. We've started testing in the LA area and leaving our robots in homes for about 5 to 6 weeks with individuals. And we're testing from all ages and ranges. This was a person with advanced Parkinson's, happened to be a woman in her 40s. And what you're seeing are two sorts of charts here. The top chart is displaying the daily activities. So if you look at that first one, it's like she commanded the robot to go 9 times to different places. One is by her TV room. The other one is, at her table where she eats, and in other locations. And what we were looking at is the persistency. This is them just commanding the robot and using it to sort of move these things and keep things within reach. And we're seeing this across our pilot users as one is repeated habit, that this is getting into a practice. Everyone so far has used it they basically commanded 100 times a month so far in their usage. But what's really interesting is when we're having the sort of post debrief with her, was looking at these spikes. Like you commanded it 13 times a day on 3 different occasions, and other days she didn't use it. And we were asking, what was different? Why did you were you sort of cleaning up, or were you sort of doing some activities around the house? And the insight was, those are my good days. And this is a woman with Parkinson's where she's got variable abilities, where on her bad days, it's pretty significant. She'll just, at the end of the day, she'll be down, get set either on the couch or on her mat, wait for the next caregiver to come, has a blanket on her, and that's sort of it. And on a good day, she's still in a wheelchair, but she has more ability to interact and do things. And what was really interesting was just basically, even from the fact that we have this very minimal version of the product with just some basic functionality, we're able to see these patterns of behavior. And we're excited, that they're using it, that they're excited to, but also that she was very willing to say, would you be willing to share with us with your caregiver or your doctor to indicate how those days are going, and are there patterns, and can we overlap that? So again, what we're doing is we're really excited to talk to folks that may be interested in either home health or in support for seniors living independently on participating in the pilots, and really appreciate the being part here. And I'm going to turn it back over to Sherry now.
Thanks, gentlemen. Awesome. When we talk about artificial intelligence and we talk about robotics and the importance of what it does in enabling an aging population to age independently, wherever that may be, what I wanted to ask you, Deepak, is I've watched your company, VirtuSense, pivot even with the pandemic. And how is what you learned from VirtuSense Balance led you into alerts, and then also into your VirtuSense One product, where you're able to monitor that older adult? We always look at falls as the decline of our aging adults, and we look at the cost of the healthcare system in the U.S. Due to falls. And what can you share from your learnings there?
Sure, Sherry. So when you start as an entrepreneur, our passion was to actually prevent falls, right? So the biggest thing we saw, the first need we initially saw was, my grandmother was never a fall risk. And we have so many physicians in our family that didn't see her as a fall risk at all. And she fell. And unfortunately, it was a bad one that resulted in her in a pretty bad situation. So what we really wanted to do was develop a technology that can actually identify people before they fall. And that's what we did with VST Balance. And when we started working with Balance, then we realized, there's about 1 million falls that happen in the hospital and 2 million falls that happen inside skilled nursing rooms every year. And it's a $50+ billion problem. It's not a small problem. So then we started developing VST1, which is more to prevent falls that happen inside the rooms. So these are for people who don't get better. Aging is a natural process. You can't fix everyone, right? There's going to be people who are not going to get better, but how do we take care of them? So rather than using a technology that is more focused like a pressure pad or a sitter that are reaction-based, so we did predictive-based with VST1, and we saw great results, about over 95% reduction in falls with injuries, right? That's beyond what most people were expecting. And then COVID hit. So, we had so many health systems we work with come and say, can you do something? We need virtual visits. We can't have nurses walk into the room. How can we see their vitals? Because there were health systems that literally put cameras that were streaming the vitals, and one camera streaming the person. So someone sitting outside every room and monitoring them. And because you had to do something to make things work. So that's when, we pivoted and added 2 core functionalities where you could do video calling and you can do virtual rounds and even let family members talk with the patients inside the rooms with a 2-way communication using the same sensor on the wall. And we had an FDA-approved product that goes on the chest, measures vitals all the time, like once every 15 minutes, right? That gave a lot of clinicians more bandwidth to take care of more patients. And it's a continually evolving process, Sherry. So once you jump in, you realize more and more problems. And what most engineers do is, let's go and fix each and every problem. But we focused on certain key things, and we took an ecosystem-based approach. So we integrate, pretty much any kind of patch today, not only ours that we provide, but any patch. So we can work with all these other technologies in the hospital, like a digital stethoscope. So that directly connects with the sensor on the wall and gets the data, puts it in the EMR. And we built the whole communication platform to get alerts on their endpoint devices, on the nursing consoles. So we built the whole chain up. So today, we're in a great position to address a lot of problems. So once we did that, then we had a lot of cardiologists and cardiac surgeons come and say, hey, could you guys tell us before a heart attack happens? Because now we have so much data. Because until now, no one had this kind of data like every 15 minutes on every patient, right? It's once every 4 or 8 hours. So then we started developing AIs to predict before a respiratory failure, before a cardiac failure, before a fall. So it's a natural process that we evolved. And for sure, we learned a lot from COVID because it forced us to innovate, because there's no scope for time. We were time pressed. We had engineers working like crazy, like 18 hours a day for 7 days a week, about 60 of them. So we did what we need to do to support our healthcare workers, our nurses, and our physicians.
So it's great to see technology evolve and to jump right into the middle of a pandemic and see the needs. We always call it solving challenges and scaling solutions, as we work with a lot of the senior living providers. And when you look at artificial intelligence, Vic, I know that's part of what your product does as well. Whoever thought that we would have a smart toilet seat? So talk a little bit about coming out of that pilot, what the reaction was from the pilot residents.
Yeah, great question. So we really started our company with a few main tenets. One is that healthcare is going to happen in the home. It's going to need to be low cost. It's going to need to be effortless. And so what we found coming out of our studies, and we work with some very large regional senior living operators in Northern California where we're based, we really have found that, number one, what has been the most eye-opening thing about our technology is that unlike almost every single other piece of technology that this industry has looked at, this requires truly zero effort to use. It's a technology that's designed to be forgotten. It's designed to fall into the background. There's no user interface. The user interface is simply replacing something that used to be a dumb piece of plastic with something that now is going to generate insightful information about human health. And so I think that's one thing that really stood out. The residents, and anyone who's been in this industry can attest to this. The residents and the operators themselves tend to be very resistant to wanting to change, and those are for very good reasons. And I think what we found universally is that the level of acceptance of this technology was extremely high, which is very unusual for them. The other thing that we found that was very interesting is that we compared what they do today with their caregivers and the effort that their caregivers take to maintain what they call these toileting activities of daily living. And they enter this information either manually or into their systems of record. And we compared that with the TrueLose ability, which is 24/7 observing this information. And we found that there were dramatic improvements in accuracy, in timeliness, in completeness of the identification of issues that require documentation and escalation. And so, I think that if you were to talk to a lot of the early users, and I know you have, Sherry, they're very excited about this because this is a very unusual type of technology in the industry. And I think a lot of people have said, look, the toilet is going to be the place in science fiction where healthcare is managed in the home. And I think that's for good reason.
Absolutely. I mean, we always think of, our older adults who sometimes may have a UTI that they don't even know they have a UTI until they happen to go to the doctor and they take the labs, or until you happen to see the outcome of that as a caregiver, and it's someone who presents with confusion or a fall. And so those are the important innovations that I think if we can get ahead of it through what you're doing, it's really preventative medicine. You called it another vital. And I think that's a good explanation. And Mike, with robotics, we always look at, I know now there's an orthopedic company who has robotics where they can actually change out a joint for a knee replacement, and it's precision. And now you've taken robotics and it's used for precision in a house for maybe ambulation. But do you even see that within assisted living and maybe even in skilled nursing?
Yeah, there's multiple applications, and I think there's one is within everyone knows probably on the call there's almost 31 flavors of senior living, and along that once you're even in a aggregate care. And I think there's a role in still like inside the apartment or inside the house for independent living, which is a lot of motivation to sort of stay as independent as they can and maintain that. What's interesting, when you go over to assisted and skilled nursing, you then are bringing a caregiver and the staff into the loop because they're part of the whole support network. Skilled nursing is actually potentially easier because you have sort of this hub and spoke model where just like the caregiver stations, the rooms and the access in and out is a lot easier. So I think that would be the next level. And we have a grant from the National Science Foundation specifically on these applications, because take that example of COVID or some infection. And if you could have the nurse, like a physical barrier, so when it's a non-trivial, if someone just needs a magazine or needs something that doesn't require full interaction, that you could be off-tasking that to a robot to go to someone. They get what they want, they're well served, and then the staff is focusing on high touch needs. And the same thing would happen within assisted living. But we build, it's almost like a laptop or phones. If we can make it work in the home, we can scale it to work anywhere. And this is a very different approach from like the hospital robots that are out there right now.
Yeah, interesting. So a question for the three of you. We're always asked, well, who's going to pay for it? And affordability, which affordability can drive adoption. As you all started to develop these products, what did you really look at as far as, is there reimbursement? Is it affordable? Who's going to pay for it? What are your thoughts around that? And then also, what do you think needs to happen for the future of healthcare when we talk about cost and adoption of innovation?
So really great point, Sherry. I mean, when we started developing products, first thing we heard is, there has to be a business model, right? I mean, you can't just make something because it's cool. Cool things are really nice, but would it really make it to the market and would you see that option? So if you see VST Balance today, we have it in a few thousands of communities across the country, right? I mean, the reason is we figured out the business model. In primary care side, we have reimbursements associated with the system. And in post-acute care, we identified ways actually it creates an ROI for various therapy providers, outpatient rehab or inpatient rehab providers. And with VST1, what we did is we actually tried to replace today the pressure pads cost you $100 just to replace the pads that are like 50-year-old technology. And a sitter costs about $18 to $35 an hour. Our technology costs about 25 cents per hour. So we are we are trying to price it in such a way that it's orders of magnitude cheaper, and it provides you, 10x more benefit, right? 1/10 the cost and 10x benefit, so that you guys could realize all this really quick. For sure, there needs to be a clear business case thought through, or else, things are going to be in the labs and things are going to be in research level, but to gain wider adoption, we need to have a business model for sure associated that gives great ROI.
Yeah, and when you try and quantify that, I've talked to some senior living communities and they're seeing 82% reduction in falls. And then you look at the litigation, that a lot of times they're impacted from litigation of falls. Mm-hmm. How have you experienced that with some of the senior living providers where you are?
Yeah, so in senior living, the average cost of litigation is about $200,000. So if you take a skilled nursing home, 100 beds average size, they have about 1 to 2 of that every year, litigations. And on top, people who fall and get injured, now they have to suck up the cost because of the Medicare Advantage plans and other risk models. So if we are reducing falls by 80+% in senior living and falls with injuries by over 90%. And if you put the stats in, we are as I said, the first 2 weeks is going to pay for the whole year of the cost of the equipment. And more important, it's going to generate a lot of good clinical outcomes that would keep seniors more healthy, and they could do things that they want to do in a better way. Once you have a fall, it's downhill from there.
Yes, absolutely.
Yeah, just echoing a little bit about what Deepak was saying. I think that for us, certainly we have made a strong effort to really validate the effectiveness in terms of healthcare outcomes and healthcare economics of our system. And I think that that's very much necessary in this, in this marketplace in order to provide solid evidence that the products that are being built are going to have an impact. And so the problem with that, of course, Sherry, as you know, is it takes time to do that. It takes time and dollars. And so that's why I think it's sometimes these innovations take a while to come to market, but I think it's a necessary process.
I can't agree more. We sunk in so much cost initially in the first few years, personally, to actually get it to a position where it is good, right? It took us 2.5 years to get the research papers. Technology was the easy part. The tough part was waiting for your publications to get through, So the first few customers always ask you for validation. After that, no one even asks you because now you got all these customers, right? It's classic healthcare. It would be really great if there was some kind of assistance or some kind of innovation grants that most of the senior living communities can get. They can try things, and if they get good outcomes, they should apply some kind of reimbursement. Let's say if we reduce falls by 70%, CMS is winning on the other side because lesser $40,000 is an ED admit because of a fall. So if you're reducing so much, they should be rewarded in a similar fashion. That would be extremely helpful.
Yes, and we have seen CMS step up on remote patient monitoring. So now you have codes for reimbursement with remote patient monitoring and telehealth. And so these are the areas that really are costly to our healthcare system that all three of you are impacting. And, even Mike there with robotics and Labrador systems, you all are looking at a population that is going to have ambulation issues. And when you start to develop where did you go originally? Did you go into the home?
We sort of checked with everyone. I think we spent a lot of time looking at assisted living because it was a more structured setting, and then realized that actually is a more complex involvement to solve. Because again, I'll give the answer to the world. The perfect robot for assisted living does everything the staff at assisted living does. Could grab the FedEx box, take that up, open up the door, put it, lock it so that no one, that it's their package is there, and run a meal from one place to the other. So it's actually, from a robot point of view, is really complex. It's the hardest one. I think what we're focusing on is the home is actually, again, it's about scalability. If you can make the product work at scale at home, it drives the economics to be much more affordable. Just like we can have home health because we have tablets. The home health industry didn't invent the iPad. That came from the consumer side. And our background, our DNA is from the consumer robotics side. So if we can apply those same techniques, get to that critical mass, and for us, it's more likely private pay is going to be, it's going to be individual paying for it, because that's so much of home care is paid that way right now. I know it's starting to change, it's starting to shift, but if we can establish that, we get the volume, and then that starts letting us then do the studies that Deepak and Victor have done and show the health outcomes that Medicare and Medicaid can start kicking in to say, hey, wow, this really improves medication adherence or hydration when you have a robot that physically brings them their pills on the time. And so that's how we're going to stage to do it. But we see home up. We have some wonderful partners from the senior living communities that are partnering with us in these early stages to prove out those early adoption cycles as well.
And when we talk about home, it could be independent living within one of the life plan communities.
Exactly. And there's even when you start talking about the cottages, I'm going to be visiting a location here in Southern California where it's a group, like it's as you know, it's a group home, but it looks like a beautiful house, with independent room and bathroom, but these wonderful common areas. And with COVID, a lot of that's changing. Like, how do we decentralize but still have efficiency in senior care? So that's what I was saying. There's all these models, and if you can be agile to that, I think it makes it better for everybody. It makes it better for the care provider and for the user to have the choice of how they want to live as they go through those stages.
Yeah, so that's what we always say, to live independently for as long as possible, wherever that may be.
Right.
One question that I want to throw out to you guys as the panelists, because this comes up a lot. These technologies require an infrastructure in place to work. Can you address some of the challenges you've had around infrastructure and what's really required?
So first, you need some level of internet, right? For all these devices to connect and have a backbone. But what we did is we developed our technology in such a way that all the processing is happening on the edge, and you don't transmit like super big video files. So we can run like 130 of our VST1 sensors on a dial-up modem. That's how much of a bandwidth we need. But especially if you take senior living into consideration, you got to really look into them. They're not going to have high bandwidth places. So you got to build something that's going to take advantage of, that's going to run on low bandwidth and probably intermittent Wi-Fi in certain situations.
What about you, Vic, Mike? Anything to add there?
Yeah, we're doing it both ways. So if someone has good broadband and Wi-Fi, then that's great. We did a study where someone there's people that are digital natives, but it's just the phone. They put the cable and the Wi-Fi to their house. So for that one, we have a mobile option. And so part of this gets into two things. One is about the privacy. So like Deepak was saying, our robot operates on the edge, meaning that its navigation, its memory, what it's doing is all locally on the robot. It's not spilling that up to the cloud, which is really important when you start having this type of device in the home. Now, it could be, if they get permission, a remote caregiver could access it, or a family member, like, hey, mom didn't respond today, is she okay? And you could do an intervention if there's the right permissions. For that, you want to have this sort of tiered approach. And the good thing, it's all coming. Like, there's still work to be done, but the fact that infrastructure with 5G and all these different, all these things that the consumer electronics and entertainment industry does, that makes our process so much more affordable to deliver. And we want to take advantage of that. So that's how we're looking at scaling. But we pretty much, the power should go out, the phone line should drop down, and you should be able to have that product work.
Yes. And Vic.
Yeah, We haven't seen it as much of an issue for our product. We try to make it take advantage of the existing infrastructure that's already in place, and so it's one of the design considerations. But as Deepak mentioned, you can't go into most nursing homes and expect that there's going to be necessarily working broadband Wi-Fi.
And another question that I'm going to throw out, because with a lot of innovators out there, and we talked to many of them in startup stage, what would you be willing to share with an innovator on what they need to be aware of when they come up with a product? I talked to someone this week, and she said her 9-year-old was asking a lot of questions and said, I want to be an entrepreneur. And so with interest, and we deal a lot with students who come through the Thrive Center as well. And we engage them with innovation for capstone projects and other things. And because we want them to see the future of healthcare. And what would you be willing to share with someone out there that has an idea and they need to know what's the best path to get it to commercialization?
The thing what we did is, you need to first create a prototype and test the market. Talk to the clinicians who are going to use it and work with them. Don't be an engineer just with 4 engineers and develop a product because no one else will use it. Work with the clinicians who are going to use it, create a quick prototype and test the water, test the market. What is the price point? Are they willing to pay? So once someone is willing to write a check, that's when you know you have a real product. Until then, I mean, you're just an entrepreneur, but you are not an entrepreneur until that point.
Yeah, just to add to that, I would say you really have to want to do it. Being an entrepreneur is not easy. It requires a lot of rejection and problems and hardship. And even though it's been lionized in the media recently, make sure that this is something that you really, really want to do, and don't expect you're going to get paid for it. You just have to really want to do it.
Yeah, and I think, just to close on that, you have to, I've done this internally within large companies, and now I'm doing it as a startup. You have to believe in that, sort of there's an end of the rainbow, in the sense of I've done hugely successful products, and people go, oh, that must have been obvious. And I remember being only like 1 of 3 people that believed in it, and everybody going, this is going to work. And what Deepak said is you really have to fulfill a real need and solve that pragmatically for folks. But then you also have to have this vision to say the world doesn't have to stay the way it is. It can change, but you have to then be that change agent.
Thank you, Sherry, Deepak, Vic, and Mike for the great discussion and for sharing your innovations and insights. We now have time for questions from the audience.
I think we've answered most of the questions from the audience that have come in through the chat. But is there anything else you all would like to share that we haven't touched on? I know we touched on a lot on value proposition and reimbursements. Is there anything else that you all would like to touch on for an audience out there that maybe we missed?
I would just, sorry, Mike. So I would just say, sometimes, it's really great looking at things. You got to really move and test the waters, do some pilots, and really quickly adapt and see what happens, right? Healthcare is changing at a very fast pace. And if you're too risk averse, or you want to do the same thing that you've been doing for the last 10, 15 years, the disruption is happening at a very, very crazy pace. So this is time where, if you really don't disrupt, you will get disrupted. So even from a healthcare delivery standpoint, so we really, sincere urge is basically for all the health system providers to jump in and start using new technologies that are game changing, design a very small pilot and see the outcomes. If it works, scale. If it doesn't, move on and do the next one. And don't be afraid to take the risk, like what startups do.
Yeah, I would echo exactly. That was going to be my point with Deepak, is I used to work on the corporate side on innovation, and the leverage effect, the folks that are in this room or are attending the conference, just that little nudge, you're not asking for millions and millions of dollars. We're just asking for a window of time you have all these entrepreneurs, all these efforts out there. And if you just give a venue, for us, when we're pitching it to investors, that's incredible credibility when we say XYZ tested this and this is their feedback. It doesn't even have to be perfect. It's like, this is what they saw positive, this is what they saw negative. That traction, that's that iterative factor. That's what Elon Musk is doing every time he shoots the rocket up, is that it just lets us improve. And I won't speak for Deepak and Vic, but we spend a ton of time just trying to get the door open, just trying to have that conversation. So that's just if you could reach out and there's all of us know each other, so we can definitely network and say, hey, there's this going on here. Just that willingness to sort of engage and do those experiments would be great.
Yeah, just to echo that, fail. I would encourage experimentation and failure on the part of health systems. Otherwise, you face some major risks moving forward.
And fail early.
Yes.
Fail fast, fail early. I mean, if something works, scale and make it work, right? That's the mantra.
Well, hello, everyone. I wanted to pop on and thank our panelists and thank our audience for all the great questions today. And you've done a great job answering the questions in the chat panel, so I appreciate that. So thank you again to our great panel, and thank you again to our great audience.